Oh,
Let's start.
carry your mind.
Okay.
Gonna mute Joao.
So I will try to present from my new computer. So if you had any problems to see my screen, just let me know, please. I'll share, and you told me if you are. Oh my God, there's a lot of options here. Let me see. Oh, I have to choose this. Done. Okay. I'll try again. Here it is. Can you see my screen?
Yes.
Okay. Now it's
Perfect.
okay.
Yeah.
Okay. So I will start. Good morning, guys. I think everyone here's already know me, but I am Natan Pereira. I'm Master in Science of Nursing and PhD candidate as well at the State University of Maringá. And today I intend to talk just a little bit about the spatial variation and place-based risk factors. So I talked with João to bring forth a meeting today, some article that talks about my methodology of the research project as well. So I choose one article to introduce some aspects of what we intend to do for my own research. The screen changed for you?
Yep, it's working.
Okay, thank you. So I put the QR code for the article that we are discussing today. That is called Spatial Variation COVID-19 Mortality in New York City and its association with neighborhood, race, ethnicity, and nativity status. I can put the link on the chat as well. Someone can help me and put the link of the article. Oh, thank you. So they have the objective in this article to investigate the relationship between COVID-19 mortality and the racial, ethnic, and immigration status composition of New York City neighborhoods. So I did a search on the literature to try to find some material that are similar to what I intend to do on one of my articles of thesis project. So this one have a lot of important information, and we intend to do something similar to this, but we intend to do some different ways to show the results as well. But I will left this to talk just a little bit later. So in this study, they did a cross-sectional approach. They analyzed data of COVID-19 between the period of February 2020 to May 2021. The primary outcome analyzed on this study was the COVID-19 mortality rate for each ZCTA, what is a zip code tabulated area. They analyzed the total number of COVID-19 deaths in a ZCTA per 100,000 population. The source of this data was the New York City Department of Health and Mental Hygiene. And there are another informations that are coming from the American Community Survey, the ACS, but also the Community Health Survey, the CHS. Talking just a little bit about the statistical analysis, the analysis used on this study consisted of a statistical model, Poisson regression models with generalized estimating equations, the DEE, adjusted for the total population of area in the New York City in this case. They calculated the mortality incidence ratio using the expected increase in the COVID-19 mortality rate for each percentage unit increase in the independent variables. And they also carried out 4 models in the nested model approach. The first model, they analyzed the racial, ethnic, and immigration status. The second one, they analyzed socioeconomic and demographic factors. The third, the health indicators. And fourth, the history of institutional discrimination. Just for our knowledge, the generalized estimating equations, the DEE used on this article, they did is a estimation technique used to deal with some correlated data. So this kind of analysis allows to model the average response while we are adjusting the correlation between some observations within the same groups, for example. In this kind of analysis, they use full likelihood. They don't use the full likelihood like in the Poisson regression habitual, but they use quasi-likelihood estimators. And the correlation in this case can be independent, exchangeables, autoregressive, and unspecified ones. So when we usually use the Poisson with generalized estimating equations, the DEE, when we are trying to counting data with intra-subject correlation, and like, for example, the number of hospitalizations at different times for the same patient, or reports of violence that occurs in different neighborhoods of the same city, or to estimate population effects, but not on a specific individual ones. So talking just a little bit about the results that was obtained on the COVID-19 study. Here are a table talking just a little bit descriptive statistics for the dependent and independent variables. So we have some values of means, standard deviations, the minimum and maximum values. What we could saw here, what we can see here, is that in all of the percentages, the native borns are higher than the foreign borns, except in case of Asians, for example, where we have the different scenario here. So talking about our maximum means, we have the native born whites with the maximum mean of our study with more than 28%. But we also have higher values for the native borns Black and native borns Hispanic as well. Now, talking about the socioeconomic and demographic variables, they introduce some informations about the CDI, the percentage of aged 65 and older, the percentage essential workers, and crowded housing units. Here in this group, we have a higher mean in the case of essential workers. So we could observe more than 70% of the cases happening in this group. And talking about the health status of the community, we have that the percentage of the participants with high blood pressure was higher in the group with more than 26%. But we also have information about the ZCTAs contained redlined area, which demonstrates us the discrimination in the area. So in this case, considering the New York City, we have a number of 177 ZCTAs. We also could see some information about the Poisson GEE models of COVID-19 deaths. And here we have the nested model approach. So the model number 1 is considered the unadjusted one, when we only have informations about the race and nativity state, ethnic and nativity status of the participants. So here we have all of the variables considered statistically significant. In the after the insertion of model 2, we have some informations model. In this model, we have the adjustment of the first variables, but we also have the introduction of two variables, socioeconomic variables, that which is the concentrated disadvantage index, the CDI, but we also have the percentage aged 65 and older and the percentage of essential or workers. So here, when we put some information about the socioeconomic status, we have that the percentage aged 65 and older was statistically significant, and the percentage of essential workers too. And we have the foreign-born Asian, the foreign-born Hispanic, and the native-born Black being considered statistically significant as well. And we have other variables that has not significance, that was significantly statistic anymore. When we insert some informations, let me look, I think it's other, oops, sorry. Let me back. Here. Here it is. In the model number 3, that is the third column here, we have the introduction of the clinical diagnosis, like the diabetes and, in this case, the diabetes. When we introduce some information about the clinical diagnosis, we could see that the patients with diabetes and this variable was not significant as well, but we have the maintenance of another variables like the percentage of 65 and older, essential workers, and the crowded housing units as well. Here it is. And in the last model, when we have all of our variables introduced in the models, we have some statistically significant variables. The foreign-born Hispanic was maintained, the foreign-born Asian as well. I think there is the native-born Black. It's significant as well. And the percentage aged 65, the essential workers, that people who was used to live in crowded housing units and with diabetes, and contained the red-lined area like the significant ones. So in this study, they gives us some figures showing the distribution of these ZCTAs. 177 ZCTAs, and here we have the rates distributed on this area. So we could see the ZCTAs and the predictive values, and we can observe that in the region of Bronx and Queens, we have the highest ones. But they also gives us some information about some ZCTAs where the model don't explain how expected the rates. For example, we could see that we have a ZCTA where we don't have any data, but we also have in the Queens, Bronx, and Staten Island some ZCTAs where the model doesn't explain the outcome, for example. So the main findings of this study is that the ZCTAs with a higher percentage of native Blacks and Hispanic and Asian foreigners had higher COVID-19 mortality rates compared to native white majority areas. And here I want to do some observation that we don't like the way of they show the results, because, for example, they don't give us a map where we can see where this population are located on. So for my study, for example, we are we're gonna try to do some different approach and to give some maps to see if the population, where this population or populational groups are located on, and after that to see if there is a association and geographic association with the outcomes as well. But for example, here we have specific topics talking about elderly. So areas with a higher percentage of elderly showed a significant increase in the mortality rates. And the same aspect occurs on the essential workers, the residential overcrowding, and the diabetes diagnosis as well. And we can conclude here that the impact of redlining was not statistically significant, but they suggest that other socioeconomic factors may be more determinant to occurrence of COVID-19 mortalities in the New York City on this period. And now, talking just a little bit about my on research. My thesis project is called Black Skin and My Voice, the Health of Young Black Brazilians from the Perspective of Necropolitics. And we have one specific objective that is to identify the spatial variation and predictive factors of hospitalization of young Black people due to socially determined diseases in Brazil. So what we intend to do based on the first study, for example, it's an ecological cross-sectional study. We intend to use informations between the period of January 2015 to December 2024 to analyze a period where we have a pre-COVID-19 pandemic period, some observations during the pandemic period as well, and some years after that. Our primary outcome gonna be the hospitalization due to socially determined diseases, because in Brazil we have a list of diseases considered by the Ministry of Health like the determined diseases, like socially determined diseases. And we have a creation in 2024 of a program called Mais Brasil or Plus Brazil, I don't know, where the Ministry of Health and the public agents in general, they intend to eradicate some this kind of diseases. For example, we're gonna have the hospitalization rate per 100,000 Black inhabitants aged between 13 and 24 years. And we selected this age group because the literature shows us that this population in this age are vulnerable to some socially changes, and this can exert some impact in all of the rest of their lives. All of the informations are coming from, some of our informations are coming from the Hospital Information System of the Unified Health System, the SIH-SUS. But we also have some informations about the population coming from the Demographic Census 2010, and continuous PNAD and other systems. And I will talk just a little bit about the systems later. I'm talking too fast, or it's okay? Okay, thank you. So the statistical analysis of my study will be carried out considering so. We intend to run the Poisson regression models to estimate some hospitalization incidence ratios associated with each risk factor and generalized estimation equations as well, the GEE, the similar for the first study to adjust for the spatial dependence between municipalities. So Brazil have 5,171 municipalities in the territory, and we're gonna analyze the rates for each one. So we intend to do a spatial analysis mapping the distribution of hospitalization rates in this territory, the calculation of Moran's index to measure spatial correlation as well, and to do some geographically weighted regression, the DWR, to identify regional patterns and to see if there is a correlation between these geographical aspects and the occurrence of the outcome. We also intend to do a nested model approach, similar to the COVID-19 study, but our models are gonna consist in the racial and demographic variables, socioeconomic factors, health and infrastructure indicators, and structural inequalities. So here I put a table. I did this table to comparison between the first study that I showed to you and the second one. So in the first one, the objective was to analyze spatial variation and factors associated with COVID-19 mortality in New York City. And in my study, we intend to identify spatial patterns and predictors of hospitalization of Black youth due to socially determined diseases in Brazil. The period for my study, it's the 2015 to 2024. The data sources, in the first study, they used some informations about the New York City. In our case, we're gonna use informations about the Brazilian hospitalizations and demographic ones and health indicators. The unity of analysis for the first study was the ZCTAs in New York City, but for my study, gonna be the municipalities of Brazilian Institute of Geography and Statistics. The dependent variable for the first study was the COVID-19 mortality rate per 100,000 inhabitants. And for my study, gonna be the hospitalization rate of Black youth per 100,000 inhabitants as well. And we have some independent variables. In the first study was the racial, ethnic, and immigration composition, age, socioeconomic disadvantage index, essential worker rates, household overcrowding, and some comorbidities, and the history of redlining. And for my study, we intend to analyze another ones, like the proportion of Black youth population, which are coming from the Brazilian Institute of Geography and Statistics as well. We also have some informations about the Human Development Index, the HDI, that is coming. We have some information coming from the United Nations Development Programme, but we also have information about this variable in the census. We also gonna analyze the poverty and inequality rate called the Gini index. The youth unemployment rate, we also have this information on the census. The average educational attainment and primary healthcare coverage, we have some informations coming from the informational health systems, and the number of hospital beds per capita. This information has come of the Ministry of Health as well, because we have some reports of the coverage of the primary health care under the territory. And we also intend to use some variables talking about the differences between the groups according to the homicide and urban violence rate. We have this information on the system of information. We have this on the violence atlas, but we also have the information coming from the mortality information system. And for the history of racial segregation and social vulnerability, we have this information coming from the census, from the Brazilian Institute of Geography and Statistics as well. But we have some reports, another reports coming from another sources. Here it is. So the first study used the Poisson regression models, the GEE, and the mortality incidence rate ratio. But in our case, to analyze the relationship between the variables and geographically informations and the occurrence of the hospitalization by the socially determined disease, we intend to do the Poisson with generalized estimating equations as well for spatial adjustments and the hospitalization incidence rate ratio. For the analysis, in the first study, they uses the Moran's index for spatial autocorrelation and also the thematic maps of mortality distribution. But in my case, we intend to use the Moran's as well and some GIS maps to visualize hospitalization rates in our territory. But we also intend to modeling with geographically weighted regression to see if there is an association about this geographic aspects and the outcome. For the nested models, they run for levels, and we intend to do some similar approach in my study, but we intend to do this according to the first one, racial and demographic variables, the second one, socioeconomic factors, and the third, healthcare infrastructure and health indicators, and fourth, the structural inequalities according to the variables that I talked to you before. And the results are expected ones in my case. In the COVID-19, they identified some areas with higher COVID-19 mortality, highlighting racial and socioeconomic disparities. And in my study, we intend to identify special patterns and predictive factors of hospitalization among the Black youth groups, providing some insights about the racial equity policies in healthcare, for example. So we are expecting some results and intend to do some reflections with my study. How I talked on the previous meeting, I will use the necropolitics theory created by Aklimi Bembe to discuss my results. And according to this theory, the state has the power to control some groups, and some groups are considered disposables or can be let to die. So we are expecting to give some results that showing us that selective logic of public health system, because we can see a discrepancy, a difference between the group's population, and this can be observed in the Brazilian territory as well. So some lives are treated as disposable, because according to this theory, and I think our results gonna show us that we have some groups that are considered disposables because they don't have conditions, for example, to basic assistance of health, or they don't receive or don't have access to primary health care, for example. And this also can let us to do some reflections, because, for example, a group that are ill, they can be considered ignored or normalized conditions, and they when they don't have the basic conditions to live, they not gonna run after their for example rights, and to conquer some aspects of their life. But also we can observe an absence from the state with some group populations. So some populational groups should be left to die, how I told you before. But also the Black population gets sicker and dies earlier. So in this way, they don't represent a risk for the maintenance of minority groups. And in this case, it's not majority, but here we have the Black population considered vulnerable ones because they suffer a lot of conditions that are not suffered by other populational groups like the white ones, for example. Here we also have the implications about the psychic suffering like a control mechanism. So how I told you before, a population that don't have health conditions, they don't try to occupation some to occupy some positions. They don't go or they don't try to conquer some rights and to conquer some spaces, for example. So in this situation, we have the maintenance of the white population, like the more, how I can explain this, with their privileges, for example. So they state here they don't have to kill directly, so they create a conditions where the disposable groups, like the Black population as well, don't have conditions to live, so they are let to die, for example. So it's not directly kill, but the state in this case create a lot of situations where this population are vulnerable to condition deaths. But we also have the deaths of young Black population do not generate public commotion because this is not an actual problem, for example. But now we intend to do some analysis and to look at these situations are more common than in the past, for example. But this doesn't mean that this kind of problem don't happen in the past. Or, for example, motivate major policies, because we have a lot of public policies of health, and we have some policies destined to these groups in Brazil, but we don't have effective ways to ensure that these policies are accessible to the population, or they are executed with some effectiveness in our population vulnerable groups, for example. And also are not even adequately recorded in official databases, because we have this information. And I also bring this kind of observation as well in the abstract that I submit to the Minority Health Conference. We have a lot of information systems in Brazil, but we keep also having some informations about race, for example, in the reports of violence that are not registered in these databases. And of course, this is a problem of the people who are notifying this, but also we also need a change in the ways of the notify and to look at these results, to look at these notifications, and to see if this kind of selective view is intentional or not. So here I put my I say thank you for the attention today. If anyone have any question, I will be pleased to answer. Thank you, and that's it.
Thank you, Natan. Can you go back to the model on the first paper?
Let me do this, is easier. Here, it's the design or the here.
I think I want to see the model results. So slide 7.
Oh, here.
Yeah.
8. The 7 is the descriptive.
Okay.
Here.
Yeah. So I'm really curious about the differences between model 3 and 2 and 4.
Mm-hmm.
It does feel like model 3 added something to the model that basically confounded the race characteristics. And then on model 4, they kind of highlighted again. That's part of the problem of these very, very complex models. So what's the difference between model 3 and 4?
Difference between model 3 and 4?
Yeah.
It's because in the model 4, we have the introduction of the ZCTA contained redlined area. It's the difference between all of the models. For example, here in the model number 1, we only have informations about the race and nativity status, for example. And in the methods of the study, they consider it the model number 1 an adjusted one, an adjusted model. And for model number 2, they insert some informations about the socioeconomic status, like the concentrated disadvantage index and percentage of olders and essential workers. So we have these 3 variables included on the models. On the model. For the model number 3, let me see. Here it is. We have the insertion of information about the diabetes. And now I don't remember, but they also have informations about, I think here they selected only the diabetes because the high blood pressure don't show statistically significance. But they also have this information in the descriptive table. But they also, they only choose the diabetes here. And it's not significantly as well. And for the model number 4, they insert the ZCTA's redlined areas. That is also not significantly as well. So basically here we can see that the outcomes that they analyzed was not significant because they intend to prove that in some areas, the redlined areas, for example, they have more COVID-19 mortality rates higher than the other areas, but the results don't show this. But shows that we have another aspects that are statistically significant as well.
Yeah.
But the focus here, Natan, was on the ethnicity and the race, right? At first,
Yeah.
at least.
Yeah.
Because at least, even though the diabetes doesn't show significance, and then the red line, I would think that this is more like controlling for possible confounders. So I don't think they need to be significant, at least to my understanding. What I would expect to see, and we see some of it, is that the effect changes a little bit from model to model. So like if you look to like native born Black, when you add the variables, the effect decreases a little bit. The mortality incidence rate ratio decreases a little bit, but it's still significant. Maybe trying to tease out what is just race versus what is race plus clinical characteristics versus what is race plus, all of that other stuff. That's my understanding.
Yeah, well, my concern is that looking at the story that Ashley was sharing, the concept of redlining, along with the concept of the social demographics, are so intrinsically connected to race that I'm concerned what's the interpretation of the last model.
Yeah, because here, looking at the regions here, for example, what we can see is that some regions that are supposed to occupied by this population, but they don't show us, for example, but they also have higher values of mortality by COVID-19, for example. And we also have some areas where
Yeah, just let's not go there yet. Go back to the table.
the table.
Yeah.
Here it is. Here. Model number 4.
What is the data on the ZCTA contained redlined area? Is it a binary data? Is it a
Yes, they consist in answers by yes or no. So they consider it a red-lined area where population suffer social disparities, if I don't, institutional discrimination. So they only have answers like yes or no. 177 areas according to the map.
Yeah. Okay. Well, the take home is, depending on your variation of race, you have an increased risk of mortality if you're coming from an area that has higher densities of different races other than white or nationally born white. That difference seems to be highly confounded by social demographics and
Elders,
predictors.
workers. Yeah. Here. Yeah, it's elders, essential workers, and crowded housing units.
Yeah. Now, on this kind of model, there's no adjustment for geographical similarity.
Yeah.
So this model is just assuming an ecological approach to take every census tract or ZCTA as an observation and then analyzing it as if they were individual observations. They are not accounting for geographical proximity, which is one of the criticisms to this paper. Okay, so that when you use other models that have some sort of adjustment for the spatial variability, either use some sort of proximity lag or some sort of similarity matrix, that might give us an idea of how much geographical variation also explains this. Now, we don't know here. All we have here for geographical characteristics is being in a red line area or not. Right. So that's something for you to think about when you're building your strategy, that we might want to bring in a model that accounts for the geographical variability or the geographical correlation of data. Okay.
But for example, if we use the GWR, we can assume that exists some influence of the area in the outcomes, for example.
Yes. So the GWR, the geographically weighted regression, is a regression that will, what they did here is what GWR outputs as the global result. So it's an analysis where you take every unit and they have the same weight in the model. So it's independent of their geographical location. What the GWR, the geographical weighted regression, does is that it looks at a particular indicator, so your outcome, looks at the geographical clustering of the outcome, and then creates subgroups and runs the regression within different groups so that you have coefficients that are specific to areas that are more similar or closer together based on a particular geographical indicator. And then you get a range of coefficients based on these groupings that are done. There's problems with that approach by definition, but it tries to tackle the problem, right? While other models like the spatial lag model will have one of the parameters in the model, the spatial relationship or the neighborhood, so how close one unit is from the other, and allows that to account for some of the variability in the outcome. So that's another way to look at this. I think it's a matter of finding one that makes more sense to the data. Okay. Now, when you go forward in this paper, go to the maps. What I didn't particularly like about this paper is that it's analyzing the census tracts or the ZCTAs in the city, but it doesn't give us any clue of what is the distribution of the data across the location. So if you know New York very well, then it's an easy evaluation. But if you don't, you have no idea where are the areas where you would expect clustering by race, clustering by redlining, clustering by demographics. That's not given to you by the paper, even on the appendix or anything else. Now, when you go to the next map, now this map could be interpreted as saying something that it's not saying, which is also what annoys me a little bit. So this map is reporting the predicted rates of COVID-19 mortality. Now, if these are the predicted rates, this is only showing me what is my guess? What is the model guessing based on true data? Now, I haven't seen the true data, so I'm not sure how good these predictions are. What this model is not, what one could interpret from this model is that the areas with darker blue are areas where you have more data, more deaths, but it's actually areas where the model is predicting more deaths, right? Now, I find this very useless to interpret because I don't want to see the predicted outcome if I can just see the actual data. What I want to see is which areas my predictors are driving the prediction if I want to try to understand a geographical problem. Okay?
And I think the same point of view can be considered when we are analyzing data from Brazil, for example, because we can't disconsider that the Brazil, for example, there's a lot of difference between the regions, because it's a lot of different when we are analyzing some data from the North region for the South region, for example. So
right. But so this is important. It's very different when I use predicted means to report the difference between groups on a trial, because in that approach, I'm trying to use a model to properly identify the effect that can be attributed to randomization. This is not the case here. So I'm not showing a comparison or anything. I'm just showing here's where my model predicted deaths, and here's where the deaths are being predicted by the model, which again, it's fairly useless in this sense, unless I'm trying to do this as a predictive task, and I'm trying to show what is the prediction as a forecasting. But in terms of just showing the reports of the model, I find it pretty useless. What I would like to see is which are the main predictors in each of these census tracts. That would be much more interesting to me. to see what is driving the issue at each location, which then could then infer what kind of policy I could think about. The next figure seems a little bit more interesting, but it's also only around the performance of the model. It's not very useful for one to come up with decisions out of it, because what this figure is showing is the residuals from the model. So the idea is that all the white spaces, which I'll take it as areas where the model is getting a pretty accurate prediction. It's between 1 and less than 1 standard deviation from the true value, from the observed value. And then any value that is blue or red are areas where the model are getting wrong. Now, if these are the areas where the model is getting wrong, the blue areas are areas where the model is getting 2 standard deviations below the observed variable. So areas where the model is underestimating deaths. If these are the same areas where you have more redlining or more socially disparate population, then the model is really not that good. But the point is, this model is more like an exploratory model. It's trying to look at the association of the predictors. So the prediction is not that relevant. Or the approach or the geographical approach here, for me, this is not really a geographical analysis as much as is an ecological analysis, and they are showing how accurate the ecological analysis is. And reason why Natan was suggesting to use GWR or something else in his analysis per se. Now, the take-home message for me here is, if you don't show the geographical distribution of your data, it's really hard to interpret whatever you model out of it. Because I really don't know if the red areas or the blue areas, which is the important piece here, are driven by the social determinants or not. And if you're just predicting the areas where you have less social inequity variability. And there is some overlap between the areas with error in prediction with the areas with higher deaths. Okay, does that make sense?
Yeah, of course. I'm reflecting about the ways that we can do this on my research, for example. Because the purpose, I think on my case, the purpose, it's exactly to show how the space can exert influence in the currency of your hospitalization. Because, for example, the diseases is socially determined as well. So we need to do some approach that shows us that the space, for example, have influence on the outcome. So in this case, to follow, to run this kind of analysis, for example, then show exactly what I intend to.
Yeah, well, I think you're in the right path, because I think they organized the analysis well enough, but the representation and the choice of doing geographical representation here didn't hit the goal, didn't hit what we were trying to get. And this comes with part of the argument that I wanted to make here is, whenever you get a bunch of outputs from your models, from your analysis, there's some outputs that are important to understand the accuracy of the analysis, but they don't necessarily feed the argument, which is what I see here. So they could be great appendixes, but not necessarily figures. And the take home that race seems to be highly associated with COVID deaths, it's an important argument that loses a bit of interest when you look at the figures, because the figures are not making that clear depiction. I would much rather see a figure that showed redlining and then race distributions and deaths, and we're able to somehow show how spatially overlapping they were. Okay.
Of course, makes sense.
So work with visuals when working with GIS, especially
Mm-hmm.
visuals on your data. They tell a much bigger story than maybe regression models.
Mhm. And one thing to consider also, Natan, for yours as well, is time. So you talked about getting a big chunk of the decade to look at how this varies for the youth population. For COVID specifically, I'm not sure if the paper goes into that, but you know, the influence of the different COVID strains, you know, the virus, the variants and vaccination rates and all of that stuff could be something to think about and to play out here for this paper. And for yours, how the time fluctuation could be a thing, and controlling for that if possible.
Of course. And we are also considering the period of study, for example, because it's impossible to do some research that considers the COVID-19 period, for example, even without consider this specific situation of health. So we put some period of 2015 to 2024, but we are still deciding how we can analyze this without a biases, for example, of the COVID-19 between this period.
Yeah.
We also have to consider this. It's very important.
All right, cool. It's time. Thanks, Natan, very much. Thanks, everybody, for showing. Hope the discussion was fruitful. We'll see you all next week.
Thank you, guys, for
Thank you all. Thank you, Natan.
the considerations as well.